Hello and welcome to another acute medicine tutorial. This tutorial covers core condition 7 from your acute medicine curriculum maps. This tutorial is about acute pulmonary embolism. The aims of this tutorial is to discuss the epidemiology of pulmonary embolism, the pathophysiology, risk factors, diagnosis, treatment, and I have some suggested resources at the end of this tutorial. So, pulmonary embolism is globally the third most frequent acute cardiovascular syndrome behind myocardial infarction and stroke. The annual incident rates for pulmonary embolism are between 39 to 115 per 100,000 of the population, and that's a global annual incident rate. What's important to know is that it is more common in those who are aged 80 years and above than those aged 50 and above by a factor of 8. What we think is that the development of pulmonary embolism is a consequence of interaction between patient-related or long-term factors and setting-related, which are more short-term. And we'll come on to those in a few slides' time. So just a reminder of the pathophysiology of pulmonary embolism or venous thromboembolism. There is a Virchow's triad, which basically reflects a combination of blood flow or stasis, vascular endothelial damage or vascular trauma, and hypercoagulability, which overlap to give the thrombosis risk. Putting these three things into more clinical syndromes, you can have, for example, a hypercoagulable state, say through pregnancy, malignancy, trauma, and sepsis. You can have stasis due to atrial fibrillation, which is why we anticoagulate atrial fibrillation. Again, it's not because of the arrhythmia is harmful per se, but it is the risk of stroke. And finally, there's the vascular wall injury, and that can be from trauma, chemical irritation, atherosclerotic disease, or indwelling catheters. We'll come on to the classification of risk factors on the next slides. So we're looking further at the pathophysiology. You have clot formation by the intrinsic or extrinsic pathways. Platelet inhibition has a minimal effect, and that's why when we are treating VTE, we don't use aspirin. Most cases around the magnitude of about 40% or so follow from a deep vein thrombosis. Of course, the pulmonary embolism will affect the circulation and gas exchange. Unfortunately, pulmonary embolism still can be fatal, and the usual mode of death is due to right ventricular failure secondary to acute pressure overload. When we have a look in more detail at the spiral of haemodynamic collapse in acute pulmonary embolism, you have increased right ventricular afterload due to mechanical obstruction by a pulmonary embolism. This then develops into right ventricular dilatation, which is a common finding on echo of those who have PE. Then you'll get tricuspid insufficiency, and then you can start to see you'll get an inflammatory state in the myocardium. The right ventricle's oxygen demand will increase, contractility will reduce, right ventricular output will reduce. This in turn, of course, will then affect left ventricular preload. Cardiac output will reduce, coronary perfusion of the right ventricle. Remember that the myocardium is supplied by its own system via the right coronary artery, and therefore you have reduced oxygen delivery, which is then your cardiovascular spiral, if you like, which then leads to obstructive shock and death. There is further details about circulatory collapse and shock in my tutorial known as Shock, which is on Moodle. Now let's have a look at a transthoracic echo. This is a long axis longitudinal slice. Although the thrombus is in the right atrium, you can see that the septum is bowed, and so therefore reducing left ventricular output. and the right ventricle is comparatively larger to the left ventricle, which normally should be the other way around. So you can see how this will look echocardiographically with right ventricular strain. The similar findings that you would see on an echo are comparable to those you would see in pulmonary embolism, although on this slide the thrombus is in the right atrium. So let's look at the predisposing factors for venous thromboembolism. The strong risk factors with an odds ratio of greater than 10 include fracture of lower limbs, previous VTE, spinal cord injury, hence the immobility, hospitalization for heart failure or acute fibrillation or flutter, hip and knee replacements, major trauma, and myocardial infarction. And it's worth noting now that a lot of orthopedic surgeons, in order to reduce orthopedic operation associated VTE, will now give them low molecular weight heparin or apixaban at low dose prior to and after surgery to prevent VTE, especially after major joint replacements. Moderate risk factors include arthroscopic knee surgery, autoimmune disease, blood transfusion, and so on. It's always important to appreciate if patients have central venous lines, if you're reviewing a patient that has been stepped down from ITU or that they are on chemotherapy, both of which are double the risk factors for VTE. So if you imagine a patient is on chemotherapy and has a central venous catheter to deliver the chemo, which is a very common thing, they're at risk of DVT. More moderate risk factors include the oral contraceptive therapy, postpartum period, and other inflammatory states. So presentation is usually non-specific, often in the immediate development of pulmonary embolism, this usually is asymptomatic. Patients may describe shortness of breath, chest pain, often described as pleuritic, although that isn't a hard indication of pulmonary embolism. Pre-syncope or syncope, you'd only see that particularly in pretty substantial pulmonary embolism. Hemoptysis, and indeed up to 40% of patients, no predisposing factors are found. Now, often when patients attend hospital and are diagnosed with PE, they've already got an established lung infarction due to the lack of oxygen and good blood supply from behind the site of the PE. So fevers and raised inflammatory markers are common. So what's on the differential? Things like acute coronary syndrome, aortic dissection, esophageal rupture. Esophageal rupture, for example, Boerhaave syndrome, is particularly when people have eaten a heavy meal, which isn't then digested properly, and then causes esophageal rupture. Pericarditis, cardiac tamponade, pneumonia, pneumothorax, and sepsis. The signs and diagnostic features of pulmonary embolism include tachycardia. This is the most common clinical and ECG finding, although again it's important to remember that 20% of ECGs are normal. Hypoxia, type 1 respiratory failure, although saturations with pulmonary embolism can be entirely normal. Raised jugular venous pressure as a sign of right-sided heart failure. Signs of shock, non-specific chest wall tenderness. Often people will quote the S1Q3T3 pattern on an ECG, which is only seen at most 25% of pulmonary embolism. Elevated troponin would suggest a massive PE, and that's again caused by the strain on the heart due to the obstruction. Positive D-dimer, and it's important to appropriately select which patients should have a D-dimer test. So for example, those who are likely to have positive D-dimers, those who are older, those who are pregnant, those who have had surgery, for example, or those who have malignancy, you have to then interpret that result with caution. So just as a reminder about what the S1Q3T3 classic pattern of PE is on an ECG, and you can see the three criteria here: the presence of S waves in lead 1, Q waves in lead 3, and inverted T waves in lead 3 also, hence the S1Q3T3. Looking at this chest x-ray here, you can see an arrow pointing to the right hilum, which is the Westermarck sign. The Westermarck sign is a sign of pulmonary embolism. The theory behind the sign is either obstruction of the pulmonary artery or distal vasoconstriction in the hypoxic lung. Roughly speaking, in one study, the POPED study, this sign was seen on about 10% of chest x-rays with confirmed PE. Radiographic features include focal peripheral hyperlucency secondary to oligemia, resulting in a collapsed appearance of vessels distal to the occlusion. In this case, you can also see central pulmonary vessels which may be dilated. So how do we decide the likelihood of whether our patient has a pulmonary embolism or not? You hopefully will have heard of the Wells score when assessing for DVT and PE, and this is the Wells score for pulmonary embolism. And you can see here that basically PE is likely if you get more than 4 points. So, for example, clinical signs and features of a DVT and a tachycardia would suggest that clinically they'll probably have a pulmonary embolism. When we compare that to the Wells score for DVT, this time DVT is likely if there's 2 points or more, and you can see how the score is calculated. So, for example, previous DVT, active cancer, and entire leg swollen would make clinically DVT likely. So this is about the PESI score, and this is slightly different to assessing the risk. This essentially is to help try and classify whether the patient is a low risk, moderate or high risk, and therefore the likelihood of death. So when you look at the PESI score, you can see the factors on the left hand side which go into a simplified and original PESI. So the simplified version, for example, looks at age, if the patient has active cancer, any cardiovascular disease, tachycardia, low blood pressure, and hypoxia. So, for example, if you have greater than 1 point, in the simplified PESI score, the 30-day mortality risk is 10.9%. So let's talk about the imaging tests for diagnosis of PE. Some of you will be probably most familiar with a computerized tomography pulmonary angiography, or CTPA, or a VQ scan. So the strengths of VQ scan, for example, is that there is relatively inexpensive, almost no contraindications, and strongly valid in prospective management outcome studies. Difficulty, of course, is you need a nuclear medicine department. With a VQ SPECT scan, which is slightly different, again, lowest rate of non-diagnostic tests, high accuracy according to the available data, and it's a binary interpretation, i.e. the PE is either present or it's not. Again, you need a nuclear medicine department to be able to provide that sort of service. Pulmonary angiography is a historical gold standard, although isn't commonly done except by my colleagues in the pulmonary hypertension department. So you'll be more familiar with CTPA. Again, it's important to appreciate the radiation. So the CTPA is a radiation effective dose of 3 to 10 millisieverts, and it's important again if you are counselling postpartum women who are breastfeeding, for example, that there is significant radiation exposure to young female breast tissue. There is also a tutorial on chest x-rays on Moodle. So let's talk about the recommendations for diagnosis. These are from the European Society of Cardiology. So in suspected PE, especially with haemodynamic instability, ideally you'd get an emergency CTPA requested from the emergency room, or you'd ask someone who could do bedside echocardiography. Echocardiography is a skill that's increasing in frequency amongst trainees. You'd also then potentially want to give them either IV heparin or a loading dose or treatment dose of low molecular weight heparin immediately if you are clinically suspicious that it is a significant PE. So without hemodynamic instability, then you have time to think about validated criteria. So for example, you can use your Wells level 2 score for pulmonary embolism. Initiation of anticoagulation is recommended without delay in patients with high or intermediate clinical probability while diagnostic workup is in progress. So what that means is that if you are still waiting for a CTPA and you think the patient is very likely to have PE, then it is prudent and therefore recommended to give, for example, what we would do ordinarily is give a treatment dose of low molecular weight heparin based on weight. So let's talk about the D-dimer test now. So this is a slightly frustrating test, a little bit like a troponin, in that it's often used without really considering the consequences of doing it if it's inappropriately done. Remember, the premise of D-dimer is that it's only really useful if the patient is low risk and it's negative. A positive D-dimer does not equal the presence of venous thromboembolism. As I've already said, there are lots of conditions that will push up somebody's D-dimer. What often happens, and for understandable logistical reasons, when patients come into A&E with, say, chest pain, the patient will automatically get a D-dimer and a troponin test. And that's partly a function of getting patients flowed through the department. You don't really want to be adding on tests late into the accident and emergency attendance. So they often get done, are often positive, and then force the dilemma of do we image or not, and do we anticoagulate or not. So again, you should always be thinking about when you're ordering a D-dimer that this should be for patients with a low or intermediate clinical probability, or that PE is unlikely. What has been a recent development in the past year or so, rather than the fixed D-dimer cutoff, a negative D-dimer test using an age-adjusted cutoff, where basically you multiply the age by 10 in patients greater than 50, should be considered for excluding PE in patients with low or intermediate probability. So, for example, if you've got a patient who has low risk feature of PE, but is 80, then the cutoff would be 800 rather than 500. And let's say the D-dimer comes back at 650, you can take that as a negative test, and that will be really useful and important in reducing unnecessary imaging such as CTPA or VQ scan. So D-dimer measurement is not recommended in patients with high clinical probability, as a normal result does not safely exclude PE. So you can see the contradiction in there, and that's why it's important that D-dimer should be used carefully. So if, for example, a patient undergoes CT pulmonary angiogram, if they shows a segmental or more proximal filling defect with a patient who has intermediate high clinical probability, then you can take that the diagnosis of PE is confirmed. You don't need to use CT venography as an adjunct to CTPA. The CTPA is a perfectly valid test. So this is giving you an example here of pulmonary embolism on CT scan, and you can see that the areas at the tip of the arrowheads are slightly darker than normal, indicating a decreased ability for contrast dye to enter the pulmonary artery, therefore suggestive of pulmonary embolism. So VQ scan, if negative, will reject the diagnosis of PE. And so, for example, where CTPA isn't possible or they are low risk, then VQ scan should be your first port of call. In reality, most patients who present to the emergency department with query PE, especially on the major side, will often have CTPA as opposed to VQ. So on the left-hand side of this slide, there are multiple images from a VQ scan, which show multiple filling defects in keeping with pulmonary embolism. So in VQ scans, PE shows mismatched defect that ventilation is present but perfusion is not. If deciding about patient who may be able to have a VQ scan, it's important that they have a normal chest x-ray. So unlike CTPA, you can have pre-existing lung disease, but in VQ scanning you cannot. So for example, if you have a patient who has COPD, for example, or pulmonary fibrosis, then these are conditions where the perfusion to the lung will be reduced. Therefore, it'll be an intermediate or probable PE and you'll get a false positive. The VQ scan does have a higher sensitivity than specificity due to the reason I've just outlined. But if it's negative, then you can stop any treatment if they're low risk. And as I'm saying, they still may need CTPA. If the VQ is positive, however, then the diagnosis is reached. So as an alternative to doing computerized imaging, then you can of course do lower limb Doppler studies, which is referred to as CUS, lower limb compression ultrasonography. So when we're thinking about the early mortality risks, basically if you have high mortality risk, then you are likely to have haemodynamic instability, you're likely to have elevated PESI score, right ventricular dysfunction, and elevated probable cardiac troponin levels. So this is the treatment regime for PE. So for example, most trusts will use one of the three on here, either enoxaparin, tinzaparin, or diltiparin, and you can see that this is primarily weight-based. However, so for example, enoxaparin, if the patient is 70 kilos, would be 70 milligrams every 12 hours. Tinzaparin would be 175 units per kilo once a day. And these are other ones that are used. So natriparin and fondaparinux are rarely used for treating PE in the United Kingdom. So if you are worried that your patient has massive PE and shows hemodynamic instability, then we should be considering about thrombolysis therapy. At the top of the page here, there is a link to one of the trusts I used to work in up in the Wirral, which has guidelines for treating massive PE with thrombolysis. But in summary, the dose as per the BNF is initially 10 milligrams IV over a couple of minutes and then followed by an intravenous infusion. Side effects of thrombolysis, of course, may include anaphylaxis. And for the patient, what is significant is that they'll basically go purple. So some of you who have watched Charlie and the Chocolate Factory might remember Violet Beauregard, who goes purple. That is the kind of colour that patients go, as effectively you are making the patient thrombolyze, you're making the blood very, very thin. Therefore, they're going to be very, very prone to bleeding. So up on here and the next couple of slides, I've got a diagnostic algorithm for suspected PE. So if the patient is hemodynamically unstable, then ideally if you can get an echo. If there is RV dysfunction or suspected RV dysfunction, then the next stage, of course, will be CTPA. Of course, if the CTPA is positive, then you can treat them. If it's negative, then of course you will need to review the causes for hemodynamic instability. And again, there is a lecture available on shock on Moodle. More commonly, your patient will have a suspected PE, but without hemodynamic compromise. Massive PE is relatively rare. So the first thing you'd want to do, of course, is take a good history. Use your Wells 2-level score for prediction of PE. If it is a low risk or intermediate probability, then doing a D-dimer is reasonable. And of course, if it's negative, you can probably discharge the patient home unless there's any other significant findings that need treating. If it's positive, you could then proceed to for the patient to have CTPA. If it's a high clinical probability or PE is likely, then you should just proceed straight to CTPA rather than waiting for a D-dimer test, or at least that D-dimer test should not change your management. So let's have a look at a risk-adjusted management strategy. So first thing you want to do is, of course, diagnose the pulmonary embolism, as we've already talked about. You want to anticoagulate the patient, assuming it's safe to do so. Now, then what you want to do is you want to effectively decide whether your patient's at high risk, intermediate, or low risk. So how do we do that? So if your patient has hemodynamic instability, then they are at high risk. Now, then the next thing you want to do is do your PESI score and see whether they are at intermediate or low risk, for example. So if you have to Hestia criteria, which you can look up in a textbook, or right ventricular dysfunction. If they have 1 or 2 present, then they are intermediate risk. If they have neither a elevated PESI score or right ventricular dysfunction, then they are at low risk. So if they're high risk, then you should consider giving them thrombolysis. If they're at intermediate risk, then you should consider performing a troponin test. If the troponin is positive with right ventricular dysfunction, it may well be that actually, in order to avoid long-term pulmonary hypertension, that you may wish to thrombolyse the patient. If the troponin is negative, then you would consider ongoing hospitalization for observation. And then if you have low risk with no other reasons and the patient is all well and hemodynamically stable, then you can discharge them home with treatment. So often we will anticoagulate the patients with one of the DOACs, so for example apixaban, rivaroxaban, dabigatran, and so on. And for patients with PE, therapeutic anticoagulation should be carried out for at least 3 months. For patients with a first PE or VT secondary to a major transient or reversible risk factor, discontinuation of oral anticoagulation is recommended after 3 months. So for example, this would be a patient who has had orthopedic surgery, who isn't undergoing any future orthopedic surgery, therefore that is a reversible short-term risk factor or a transient risk factor, therefore the likelihood of PE is significantly reduced in the future, so that patient would only need treating for 3 months. So patients who you would consider extending anticoagulation, particularly patients who have recurrent VTE, cancer and so on, or have ongoing risk factors. If you have antiphospholipid syndrome, then you would use a vitamin K antagonist, and that's one of the few conditions these days in which you would use warfarin as opposed to a DOAC. Other conditions in which you should consider extension of anticoagulation are those who develop PE with no identifiable risk factor, and remember that that can occur in up to 40% of patients. If you have first PE associated with persistent risk factor other than antiphospholipid syndrome, then again you should be considering extending anticoagulation. So if extended oral anticoagulation is decided after PE in a patient without cancer, then you can prescribe a reduced dose of apixaban, for example, 2.5 milligrams BD, or rivaroxaban 10 milligrams once a day should be considered after 6 months. In patients who refuse to take or are unable to tolerate any form of oral anticoagulants, aspirin or Sulodex may be considered for extended VT prophylaxis, but this really should be strongly discouraged as clinical practice, as there are real risks of developing VTE if the patient is only taking aspirin. Patients will be followed up by the anticoagulation service. So the next couple of slides here, which you can read, are about the treatment of PE in patients who have cancer. As you can see, for patients with PE and cancer, weight adjustment subcutaneous low molecular weight heparin should be considered for the first 6 months over a vitamin K antagonist. So this slide here is about the diagnostic workup for suspected PE during pregnancy and up to 6 weeks postpartum. Now you can see for obvious reasons that the diagnostic algorithm is a little bit different, so let's go through it. So if there is a high pretest probability, then you should anticoagulate with low molecular weight heparin and arrange a chest x-ray. Rather than proceed straight to pulmonary angiography, then you should do a duplex ultrasound or a Doppler. And then you can see where if there's a DVT present, then of course the patient will get anticoagulated without the need for doing CTPA. If a proximal DVT is not present, then you could proceed to a normal chest X-ray for CTPA or perfusion lung scan. If both of those are negative, then PE is ruled out. So if the CTPA is positive or there is a proximal DVT, then you should continue with low molecular heparin at the therapeutic dose. And of course, you'd want to discuss the delivery plan with your obstetricians. So, PE can cause significant long-term sequelae if not picked up early and monitored carefully. So, after the diagnosis of anticoagulation as a standard, either the respiratory or the acute medicine clinic will follow up these patients at 3 to 6 months. You will want to assess them clinically, whether they have any signs of heart failure or ongoing shortness of breath. Then you'd want to organise a transthoracic echo to see if there's any probability of secondary pulmonary hypertension. If there are signs of pulmonary hypertension on any of the tests that you do, then it would be worth referring the patient to a pulmonary hypertension service, such as the one that we have at the Royal Free. So in the last slide, there are a couple of resources here. So there are details on the European Society of Cardiology guidelines. There is also an app that you can download and register to get the guidelines for a wide variety of acute cardiac conditions onto an app on your phone. There's also the clinical knowledge summaries for NICE, and also there's an article on thorax, the Journal for Respiratory Medicine, about management of PE and thrombolysis. Remember that there is a Q&A section on Moodle for acute medicine, or you can contact me via email. Please like or subscribe on YouTube. Thank you for listening. Take care of each other, and we will have another tutorial for you soon.